Welcome back guys. Now in this video let's discuss about the topic of maternal pelvis. Guys, pelvis was divided into a true pelvis, false pelvis. We know that. So the part of pelvis through which the baby is actually passing through during the labor, that's known as a true pelvis, and the pelvis which is above true pelvis is known as false pelvis. So what is that demarcation point which differentiates or which divides true pelvis from false pelvis? So it's the pelvic brim. So pelvis was divided into true pelvis and false pelvis by pelvic brim. If you see here, see, this is what is known as a pelvic brim, also known as a pelvic inlet. So above pelvic inlet, whatever you are saying, so this part of pelvis is considered as false pelvis, which is not obstetrically significant, and the part of pelvis below this pelvic brim, so this part is known as a true pelvis. Why? Because it is obstetrically significant. Why? Because baby is maneuvering through that pelvis. Now, what are the boundaries of the pelvic brim? If you ask me what are those boundaries, we have to start from here and go along like this, and we have to end here. Why? Because same will be on the vice versa. So what are the demarcation points, or what are those points which are actually forming the pelvic brim? Guys, please concentrate. We have to start with the sacral promontory. Here posteriorly, let's start with the sacral promontory. After sacral promontory, there are these sacral alae. Okay, so sacral alae are forming the pelvic brim. After sacral alae, there is this joint known as sacroiliac joint. After sacroiliac joint, there are these iliopectineal lines followed by iliopectineal eminence. After that, there is the superior border of superior pubic rami, okay, superior border of superior pubic rami, followed by pubic tubercle, pubic crest, and upper border of pubic symphysis. So at the end of the day, what I am trying to put into your mind is that, see, they can ask you MCQs like, what is the order of structures which are coming in the line of pelvic brim? So let's start with the sacral promontory posteriorly and come anteriorly. So you can clearly see here that sacral promontory followed by sacral alae, sacroiliac joints, iliopectineal lines, iliopectineal eminence, upper border of suprapubic rami, pubic tubercle, pubic crest, and upper border of pubic symphysis. Okay, these are the landmarks which are forming the pelvic brim. Now let's see some abnormal pelvis. Guys, for example, there is this pelvis called as Robert's pelvis. Here in Robert's pelvis, there is absence of both the sacral alae. For example, see here guys, see, this is one sacral alae and this is the other sacral alae, the sacral wings. What happens if both the sacral alae are missing? Then the resultant pelvis will be absolutely abnormal. So such a pelvis is known as Robert's pelvis. And Naegele's pelvis. What exactly is this Naegele's pelvis? What's happening here? There is absence of one sacral alae. If both the sacral alae are absent, then it is known as Robert's pelvis. If only one sacral alae is absent, that is known as Naegele's pelvis. Now, rachitic pelvis is seen in rickets. For example, we know rickets is a condition which is associated with the abnormal bones. Okay, so because of the deficiency of vitamin D during childhood, there is improper bone formation. So such an abnormalities can lead to rachitic pelvis. After seeing abnormal pelvis, let's see what are the different parts of a true pelvis. Guys, when I am discussing about true pelvis, this true pelvis was divided into three parts. See, there is this inlet, okay, inlet, outlet, and cavity. Now in this lecture, we are going to discuss first about the inlet, cavity, and outlet, and all the important MCQs, what and all needs to be covered, that will be covered. Now let's begin with the inlet. Guys, if I am talking about pelvic inlet, in a female, the pelvic inlet shape is round, okay, round in shape, or I can say transversely oval. This point is very, very important. The inlet, whatever I am talking, see, the inlet is transversely oval. For example, it is something like this. Why I am saying like that? Because the antero-posterior diameters, for example, here is the pubic symphysis, here is the sacrum. Okay. Now, this is the transverse diameters. The transverse diameters are more when compared to antero-posterior diameters. The transverse diameters are more when compared to antero-posterior diameters. So the inlet is transversely oval. It will be something like this. Okay. Now, that's a very important point. See, narrowest antero-posteriorly and widest transversely, which means the transverse diameters are greater than the antero-posterior diameters. Those diameters which we'll discuss. Okay, don't worry, we will discuss. Now, what is the angle of inclination? Guys, see, if I am talking about pelvic inlet is not something like this horizontally. Okay, it's not exactly like this in the one plane. You see, it is more angulated, it's more tilted. Now, if you can see here, see, this is the inlet, right? So, this is the inlet and this is the outlet, for example. See, the inlet, it's not in a normal horizontal plane, it's more of angulated. So, that angle is known as angle of inclination. See here, it is somewhere around 55 degrees. So, with the horizontal, the angle of inlet is 55 degrees. Okay, so that's a very important point which needs to be kept in mind. So, again I am reminding, pelvic inlet, it is transversely oval. The transverse diameters are greater than the antero-posterior diameters. Now, after that, let's talk about the diameters of pelvic inlet. See, when I am talking about pelvic inlet, this is what I am talking, right? Yes, this one. See, the pelvic inlet, it have three diameters. What are they? Antero-posterior diameter, this one. Okay, antero-posterior diameter, transverse diameter, and oblique diameters. There are three diameters to the pelvic inlet. Now, as I have discussed, there are three diameters of pelvic inlet. Now, let's begin with the antero-posterior diameters of the pelvic inlet. Guys, I am starting with antero-posterior diameters of pelvic inlet. Now, please concentrate here. How many antero-posterior diameters are there? See, there are three antero-posterior diameters. For example, concentrate here. Sacrum lies in the posterior part. Pubic symphysis lies in the anterior part. This is anterior and this is posterior. So, antero-posterior diameters. Usually, how many antero-posterior diameters are there? If you are thinking logically, you will say, there is only one antero-posterior diameter. But it's not. See, let me tell you one thing. If this is the sacral promontory, for example, this is sacral promontory. And anteriorly, there is pubic symphysis. Pubic symphysis is not a one single point. Okay. So, how many diameters are possible? One diameter is from sacral promontory to the tip of the pubic symphysis. This is one diameter. Sacral promontory to the lower border of pubic symphysis, that's other diameter, and from the sacral promontory to the middle of the pubic symphysis. So, this is one more diameter. So, what I am trying to put into your mind is, in antero-posterior diameters itself, there are again three. So, they are remembered as TOD. T for true conjugate, obstetric conjugate and diagonal conjugates. So, please concentrate guys, from the tip of the sacral promontory to the tip of the pubic symphysis, this is known as a true conjugate. From the tip of the sacral promontory to the middle part of the pubic symphysis, that is obstetric conjugate, and from the tip of the sacral promontory to the lower part of the pubic symphysis, that is diagonal conjugate. So, now please repeat with me. So, how many antero-posterior diameters are available guys? 3 antero-posterior diameters are available. Now, let me draw it again for you so that you will get a logic. For example, if this is the sacral promontory and here is the pubic symphysis. Now, see what I am drawing right now, it is the true conjugate. See, this is a true conjugate and this one is obstetric conjugate and the last one is diagonal conjugate. Now, just by looking at it, say me which conjugate is having largest diameter. Okay, it's very simple that the last one, diagonal conjugate, will be having largest diameter, and which conjugate will be having shortest diameter? It is obstetric conjugate. Why? Because it is something coming like this. So, the diameter will be very much, the length will be very much less. So one important point is that the diagonal conjugate is having largest antero-posterior diameter and obstetric conjugate is having smallest antero-posterior diameter of pelvic inlet. Now why I am saying this? See guys, out of all these three antero-posterior diameters, who is the smallest one? It is the obstetric conjugate. As it is smallest, it is obstetrically significant. So larger diameters are there means not a problem, but smaller diameters are very much important. Why? Because baby have to pass through. So very important point is, out of all these antero-posterior diameters, obstetric conjugate is the one which is highly significant. Now please concentrate. See, true conjugate, it will be somewhere around 11 centimeters. That is this one. Okay, 11 centimeters. Now obstetric conjugate, it will be 10 to 10.5 centimeters. That is, the second one is having 10 to 10.5 centimeters. And if I am talking about diagonal conjugate, see, it will be 12.5 centimeters. 12.5. Now let me ask you a question. Out of all these antero-posterior diameters, which diameter is clinically measured? Okay, with fingers you can only measure diagonal conjugate. Yes, diagonal conjugate can be measured. See, here you can have your fingers, but how can you have your fingers in this particular area or in this particular area? No, you cannot. So the only conjugate which can be clinically measured is diagonal conjugate. But which conjugate is obstetrically significant? That is obstetric conjugate. So how to estimate obstetric conjugate? Guys, please concentrate. Again I am repeating, the only diagonal conjugate, okay, only diagonal conjugate can be clinically assessed. But how to assess the obstetric conjugate? In order to have an idea about obstetric conjugate, what you have to do is, see, you have to subtract, okay, subtract 1.5 to 2 centimeters from the diagonal conjugate. Whatever the value you are getting, okay, you are measuring, you are trying to get the diagonal conjugate. Whatever the value you get, from that value minus 1.5 to 2 centimeters, then you will be getting the obstetric conjugate. Very important MCQ, how to get the obstetric conjugate? Subtract 1.5 to 2 centimeters from diagonal conjugate. And what is the largest antero-posterior diameter of pelvic inlet? The largest antero-posterior diameter of pelvic inlet is diagonal conjugate, and smallest antero-posterior diameter of pelvic inlet is obstetric conjugate. As it is the smallest diameter, it is most important diameter. Now we have seen all the antero-posterior diameters of the pelvic inlet. So antero-posterior diameters are completed. After antero-posterior diameters, we have transverse diameters and oblique diameters also. Now let's talk about the transverse diameters. I have already said you, the pelvic inlet is transversely oval, which means the transverse diameters are greater than the antero-posterior diameters, and transverse diameters are the largest diameters of the pelvic inlet. Okay, out of all the diameters of pelvic inlet, that is antero-posterior, transverse and oblique, the transverse diameters are the greatest diameters. Okay, see, it is the largest diameter of pelvic inlet. But if someone asks you what is the largest antero-posterior diameter, then it is diagonal conjugate. Okay, so what exactly are these transverse diameters? See, these transverse diameters are two distant points on the iliopectineal lines. Here will be one iliopectineal line and here will be other iliopectineal line. So the distance between these two iliopectineal lines is the transverse diameter. And how much it will be, guys? It will be 13 centimeters approximately, 12.5 to 13 centimeters. Okay, so that's a very important point. Now after this, see, if transverse diameter is less than 12 centimeter, it should be considered as contracted pelvis. Guys, what exactly is contracted pelvis? Now, if this transverse diameter is less than 12 centimeter, such a pelvis should be considered as contracted pelvis. Okay, why? Because the baby cannot pass through such smaller diameters. Okay, now after this, let's talk about the oblique diameters. Guys, oblique diameters means, for example, on the right side, right oblique diameter runs from right sacroiliac joint to left iliopubic eminence and vice versa. Okay, so right sacroiliac joint to the left iliopubic eminence. In the same way, left sacroiliac joint to right iliopubic eminence. So the distance between these 2 points are considered as oblique diameters, and oblique diameters will be somewhere around 12 centimeters. Again I am repeating, out of anteroposterior diameters, transverse diameters are like oblique diameters, which diameters are largest? Okay, which diameters are the largest diameters in the pelvic inlet? It is always transverse diameters, okay, transversely oval. Now after this, we have seen all the diameters of the pelvic inlet, that is anteroposterior, transverse and oblique, completed. Now we have to discuss about the pelvic cavity. Inlet is completed, inlet or pelvic brim is completed. Now we have to discuss about the cavity. See guys, again I am repeating, this is the inlet. About inlet completed. Now this is outlet. Still we have some time to discuss about the outlet. What we have to discuss? So this in between area. So this area is known as pelvic cavity. Now what are the boundaries of the pelvic cavity? Guys, please concentrate here. Superiorly, who is having? Guys, if I am saying this is inlet and this is outlet, for example, this area is considered as pelvic cavity. So for a pelvic cavity, who is superior? The superiorly it is having pelvic brim or pelvic inlet. True. Inferiorly it is having pelvic outlet. Yeah, inferiorly there is pelvic outlet and superiorly there is pelvic inlet. Okay. Anteriorly who is there? Anteriorly there is this pubic symphysis and posteriorly there is sacrum. So these are the boundaries of pelvic cavity. Okay. So this is a pelvic cavity. Now what are the important points you need to keep in mind? Guys, this pelvic cavity having both anteroposterior and transverse diameters as 12 centimeters. Okay, both anteroposterior diameters and transverse diameters. For example, let me show you in a simple image. This is pelvic inlet, this is pelvic outlet. The in-between area, this is pelvic cavity. Now this pelvic cavity having anteroposterior diameters and transverse diameters, it is one and the same, 12 centimeters. But very important point is that in this pelvic cavity, there is this one particular area where the ischial spines are protruding into the cavity. Ischial spines are protruding into the pelvic cavity. So what happens? So here the diameters will change. Okay. And also if I am cutting here, if I am taking a section over here, that's the plane. So this plane is having the least pelvic dimensions. Okay, the diameters are going to be very much less. So this is known as plane of least pelvic dimension. Okay, exactly. I'm going to take a plane at the level of ischial spines. So please concentrate. In the pelvic cavity, there is an area where ischial spines are protruding into the cavity, making the pelvic dimensions very, very lesser. That's the least. So it is known as plane of least pelvic dimension. What is the importance, guys? First of all, let's see where exactly it lies. See, it is a plane passing through mid pelvis. Yes, passing through the cavity or mid pelvis, connecting lower border of the pubic symphysis anteriorly. So from the lower border of pubic symphysis anteriorly, ischial spines laterally. See, here is the ischial spine. I am taking exactly plane. Okay, and this plane is joining between S4, S5 sacral vertebra. Okay, junction of S4, S5 sacral vertebra posteriorly. So this plane is having least dimension, lesser diameters, that is known as plane of least pelvic dimension. Guys, why I am stressing so much? Why? Because the diameters are getting so much narrow over here. If the diameters are getting so much narrow over here, what happens? There can be a lot of problems associated. See, baby is passing through the pelvic cavity. There is this area where least pelvic dimensions are there. So what happens? There can be arrest of the baby in that particular area. So, chances of deep transverse arrest are more near plane of least pelvic dimension. Because the diameters are so much less in this particular area, baby is trying to maneuver through this narrow area. So that is known as internal rotation. See guys, in this slide, I am showing you all the important events which are happening in the plane of least pelvic dimension. So please concentrate guys. This is the area where ischial spines are protruding into the cavity and making the pelvic cavity narrower. And as the area is more narrower, deep transverse arrest can occur at this level. True. And as the area is so much narrower, baby will try to maneuver through that area. That process is known as internal rotation. Baby is rotating internally in the cavity, okay, to come out of that area. So internal rotation occurs at this level. And external os, external cervical os also lies at the same level, and it is the site for the pudendal block. So what are the important points about plane of least pelvic dimension guys? Internal rotation happens here, chances of deep transverse arrest, site for the external cervical os and site for the pudendal block, and ischial spines are protruding in. So this area where ischial spines are protruding in, that area or that plane is considered as zero junction, okay, or zero station, okay. So what exactly is zero station? So the level at which ischial spines protruding into the cavity, it is known as zero station. What is the importance of zero station? We will discuss in the next slides. Let's talk about diameters of mid pelvis, or the diameters of plane of least pelvic dimensions. I am saying this area is the narrowest area. Please concentrate. Here the antero-posterior diameters, for example, which means anterior and posterior diameters. Antero-posterior diameters will be somewhere around 11 to 11.5 centimeters. Okay, this is not something bad. Antero-posterior diameters are considerably good. But please concentrate here. The interspinous diameter in between the spines, see, you can clearly see here that into the pelvic cavity, these spines are protruding in. So interspinous diameter is just 10 centimeters. Narrowest area. Chances of deep transverse arrest can occur. So very important point is that, see, the diameters of least pelvic dimension or the diameters of mid pelvis is antero-posteriorly, it is somewhere around 11 to 11.5 centimeters, but transverse diameters or the interspinous diameters are just 10 centimeters. Okay, so interspinous diameter or bispinous, which means between both the spines. Now important point is that the interspinous diameter is the smallest diameter, okay, is the smallest pelvic diameter. Out of all the pelvic diameters, interspinous diameters is at most important because it's the smallest out of all. Okay, so that's a one important point you need to keep in mind. Now after this, let's talk about the pelvic outlet. Guys, it lies at the level of ischial tuberosity. Not ischial spines, ischial tuberosities, okay. These are the tuberosities, ischial tuberosities. Now, let's see the borders. Guys, what are the antero-posterior diameters? Remember, from the lower border of the pubic symphysis, see, this is the lower border of pubic symphysis to the tip of the sacrum. Guys, when I am discussing about plane of least pelvic dimension or mid pelvis, antero-posterior diameters, please concentrate, antero-posterior diameters are from lower border of pubic symphysis to the junction between S4 and S5. It's not the tip of the sacrum. But if I am talking about pelvic outlet, the antero-posterior diameter should be taken from lower border of pubic symphysis to the tip of the coccyx. And if I am talking about transverse diameters, the transverse diameters are also known as bituberous diameters, which are extending between ischial tuberosity on one side, okay, to the other side, in between both the ischial tuberosities. So it can be called as a bituberous diameter. It will be somewhere around 11 centimeters. Guys, very important point to be noted is that, see, the transverse diameters are considerably less when compared to antero-posterior diameters. Can you able to understand something? See, at the level of inlet, transverse diameters are more when compared to antero-posterior diameters. But when I am coming to the outlet, antero-posterior diameters are more when compared to transverse diameters. Yes, this is a very important point, that at the level of inlet, transverse diameters are greater than the antero-posterior diameters, but when you are coming to the outlet, antero-posterior diameters will be more than the transverse diameters. So it's not just like a perfect cylindrical structure. Okay, the pelvic cavity or this true pelvis is not a perfect cylindrical structure. Okay, and like at the level of inlet, transverse diameters are more, but when it's coming to the outlet, anteroposterior diameters are more. That's the reason why baby is twisting and turning in order to pass through this cavity. Why? Because the dimensions are not perfect. Okay, that's the reason why baby is trying to maneuver through this, abnormal, we cannot say abnormal structure, but the dimensions are getting varied from inlet to the outlet. Now, after this, let's talk about subpubic angle. Guys, we have completed inlet, cavity and outlet. Now, let's see what is the importance of this subpubic angle. Guys, when compared to male, okay, when compared to male pelvis, female pelvis having less subpubic angle. Not less subpubic angle, I should say the subpubic angle is more obtuse, Please see here, this is male pelvis. In male pelvis, the angle is so sharp. Okay, so it is a very acute angle. The male pelvis is going to have a very sharp angle, that is acute angle, and a female pelvis is more broader and it will be having more obtuse angle, which will favor the easy delivery of the baby. So at the end of the day, what I am trying to put into your mind is female pelvis have obtuse angle. Okay, obtuse subpubic angle, this one. But males have very sharp subpubic angle. Okay, now after this, let's see Caldwell and Mole classification of pelvis. Guys, this is very, very important. They will ask you, what is the classification system used for classifying pelvis? It is Caldwell and Mole classification of pelvis. Now, there are 4 different types of pelvis: gynecoid pelvis, android pelvis, anthropoid pelvis and platyploid pelvis. Okay, see, out of all, gynecoid pelvis is most common. Android pelvis means male type pelvis. Okay, android means male like pelvis. Anthropoid, anthropos means ape like. Okay, ape like pelvis is the chimpanzee thing, and platyploid pelvis means bowel like pelvis. Okay, bowel like. Now let's see what are the important differences between different kinds of pelvis. See here. Now let's begin with the gynecoid pelvis. Gynecoid means a female pelvis and most common pelvis. I have already said to you, in females, the shape of inlet is transversely oval. Yes, we have already discussed that inlet will be having transversely oval. Now, the transverse diameters are greater than, at the level of inlet, transverse diameters are greater than antero-posterior diameters. We have already discussed. The pelvic side walls, see, in order to facilitate the delivery, the pelvic side walls, they are broad and parallel. Okay, so having broad and parallel pelvic side walls will facilitate the delivery more conveniently. But if I am talking about android pelvis, see, the shape of pelvic inlet is more of heart shape. Here also, please concentrate, here also the transverse diameters are greater than antero-posterior diameters. See, in both gynecoid as well as android pelvis, transverse diameters are greater than the antero-posterior diameters. But one important point is, you can clearly see here the ischial spines are protruding into the cavity. See, even in female pelvis, the ischial spines are protruding into the cavity, but here more prominent, okay, they are protruding deep into the cavity. So, if a female is having android pelvis, what happens? The ischial spines are protruding deep into the cavity, that can cause deep transverse arrest. Okay, so one important point is, if a female have android type of pelvis, now she can have deep transverse arrest during normal vaginal delivery. And also have discussed the ischial spines are prominent. Now, see, having such a android pelvis, okay, what's the main problem? The main problem here is that deep convergent side walls. because the side walls are so much convergent means they are coming together. Okay, I have already said you that the angle between the subpubic angle is more acute. Because the subpubic angle is more acute, the pelvic side walls are coming close together. So that also cause a problem during delivery. So pelvic side walls are not broad and parallel, they are more convergent. So very important MCQ, in android type of pelvis, the pelvic side walls are more convergent, and in gynecoid type of pelvis, the pelvic side walls are broad and parallel. Now, this type of pelvis is also seen in dystocia dystrophica syndrome. So, direct MCQ, what type of pelvis is seen in a female who has dystocia dystrophica syndrome? It is android type of pelvis. We will see in detail about dystocia dystrophica in a later lecture. Okay, in this slide, what are those important points you need to keep in mind? Female pelvis is something most common. It is having transversely oval outlet. Anteroposterior diameters are lesser than the transverse diameters, or transverse diameters are greater than anteroposterior diameters. And pelvic side walls are broad and parallel. Male pelvis, heart-shaped pelvic inlet. Ischial spines are more prominent. They can lead to deep transverse arrest. Pelvic side walls are more convergent. And this type of android pelvis is seen in dystocia dystrophica syndrome. Now after this, let's talk about anthropoid pelvis. Anthropoid means ape-like pelvis, which means something a little different from usual. This is something unusual pelvis. See, so far what we have discussed, in both android pelvis and gynecoid pelvis, transverse diameters at inlet, transverse diameters are greater than anteroposterior diameters. But here in anthropoid pelvis, the only pelvis where anteroposterior diameters of inlet are greater than the transverse diameters. So very important point. See, it is anteroposteriorly oval. See, in gynecoid pelvis, it is a transversely oval, here also transversely oval, which means the transverse diameters are greater than the anteroposterior diameters. But the only pelvis where anteroposterior diameters are greater than transverse diameters, which means the pelvic inlet will be something like this, which means the anteroposterior diameters. For example, if here is the anterior diameter, this is anterior and posterior. So anteroposterior diameters are greater than the transverse diameters. Okay, now having such a pelvis, okay, if there is such a pelvis, there are more chances of occipito-posterior position. What does it mean by occipito-posterior position? Guys, usually, please concentrate here, usually this is how it should be. Baby should be getting engaged into the pelvic cavity by occipito-anterior position, which means the occiput should be towards the pubic symphysis. Occipito-anterior position is something normal. But having an anthropoid pelvis, it favors occipito-posterior position. Please concentrate, if occiput is towards the posterior position, the face of the baby is facing towards the pubic symphysis. Am I right or not? Yes. So, if someone asks you, phase 2 pubic delivery, phase 2 pubic delivery is most commonly seen with which type of pelvis? Anthropoid pelvis. So, a very important point is that concentrate here, phase 2 pubic delivery is seen in anthropoid pelvis. Okay, now one more important point. See, engagement happens antero-posteriorly. What is this? Guys, let me ask you one thing. In gynecoid type of pelvis and android type of pelvis, how the engagement is happening? Engagement is like, the baby's head is coming into the pelvic cavity. How it is happening? Guys, in both android and gynecoid type of pelvis, the transverse diameters are more. So, engagement is also happening transversely. We say that in gynecoid and android pelvis, as the transverse diameters of inlet are more than anteroposterior diameters, so engagement is also happening transversely. We will discuss in detail in the topic of labor. But please concentrate, in anthropoid type of pelvis, as anteroposterior diameters are more, the engagement is happening anteroposteriorly, and that causes occipito-posterior position, most common, that leads to phase 2 pubis delivery. And if you see pelvic side walls, they are parallel and narrow. Now after this, let's talk about the final pelvis, that is a platyploid type of pelvis. What exactly it meant by platyploid type of pelvis? This is a bowl-like pelvis. What does I mean by bowl, guys? For example, if I am drawing a bowl over here, for example, this is bowl. What is the characteristic of a bowl? See, a bowl will be having a bigger transverse diameter when compared to antero-posterior diameter. If I am saying this is anterior and this is posterior, see the antero-posterior diameters are lesser than transverse diameters. See, same will be true with gynecoid pelvis and android pelvis, right? See, even in gynecoid pelvis and android pelvis, transverse diameters are greater than antero-posterior, transverse diameters are greater than antero-posterior. But here, please concentrate. Transverse diameters are greater than antero-posterior diameters, which means the pelvic inlet, the transverse diameters are so much big. So that is just looking like a bowl shape. So bowl-like pelvis is platyploid type of pelvis. Okay, just looking like a flat bowl. Transverse diameters are greater than antero-posterior diameters. Now, engagement happens with marked asynclitism. What does I mean by marked asynclitism? See guys, the transverse diameters are much more greater than antero-posterior diameters. So there is so much amount of space for the head to engage. See, in a normal pelvis, the head is going to exactly fit into the inlet. But now there is so much space that a head can easily tilt. So tilting of head towards the shoulders is known as asynclitism. Let me show you. See here, the head is tilting. So here, if the transverse diameters are more than anterior posterior diameters, because of so much availability of space, the head can easily tilt. So that is known as asynclitism. So marked asynclitic engagement is seen with platyploid type of pelvis. Because of this tilting, the engaging diameters, the engaging transverse diameter is super subparietal. So guys, let me tell you what is normal. Okay, see, if head is normally getting engaged into pelvis, then the engaging transverse diameter is, okay, the engaging transverse diameter is biparietal diameter. Okay, so parietal bone, biparietal diameter is going to be engaged. But if it is little bit tilted, do you think biparietal diameter is the engaging diameter? No, the engaging diameter will automatically change. Because of this tilting, now the engaging transverse diameter will become super subparietal diameter. So just with the tilting, the engaging diameters will change. Yes, just with flexion and deflection, engaging antero-posterior diameters will change. Just with flexing, the engaging transverse diameters will also change. So usually the engaging diameter is biparietal diameter. But because of marked asynclitism, the engaging diameters will become super subparietal. And here the pelvic side walls are more divergent. Where we have seen convergent pelvic side walls are seen with the android type of pelvis. Okay, deep, like protruding ischial spines into the cavity. Okay, so this slide is a very important way because you can expect one MCQ from this slide. Now after this, we have seen the positions. Okay, see here. This is the level at which ischial spines are protruding in. I have said you, this level is considered as zero station. Okay, zero station. So if the baby's head is above zero station, we will be calling it as -1, -2, -3. Okay, -1 station, -2 station, -3. If baby's head is coming down this zero station, +1, +2, +3, which means the baby is coming down. Okay, these are the demarcation points, these are the landmarks to say where exactly the baby is. Very important point, the place where ischial spines are protruding is zero station. Okay, now after this, asynclitism completed. Now let's talk a few points about contracted pelvis. Guys, we have discussed so many diameters, right? Now, what if any of those diameters are lesser? Okay, so the major diameters are getting narrower. For example, see, if any of the major diameters are shortened by 0.5 centimeters or more, okay, the diameters are getting narrower, which means the pelvis is getting narrower. That is, pelvis is a contracted pelvis. Now, just think logically. If pelvis is a contracted Do you think normal vaginal delivery can occur? No. So, in a contracted pelvis, the question is something like this. In a contracted pelvis, what is the mode of delivery? It is simple C-section, always C-section. Okay. Now, so contracted pelvis, is it an indication of C-section? Yes, absolutely. It is an indication of C-section. There is no doubt. Now, please let's discuss something like, little important. Out of all the diameters of inlet, okay, out of all the diameters of inlet, what is the most important diameter? It is the obstetric conjugate. So, the most important antero-posterior diameter is obstetric conjugate. Why? Because it is the smallest diameter. Now, how much it is usually? Usually it is 10 centimeters. What if obstetric conjugate is less than 10 centimeters? Then we can call the pelvis as contracted pelvis. Now, for example, this contracted pelvis was divided into little bit like degrees or grades. For example, mildly contracted pelvis, which means the obstetric conjugate is between 9.5 centimeters to 10 centimeters. Usually it should be 10 centimeters, but now in this female, for example, if it is 9.7 centimeters, yes, it is less than 10, but it's mildly contracted. What if the contraction is moderate, that is 7.5 to 9 centimeters. Severe degree contraction is less than 7.5 centimeters. Guys, very important. Why I am saying all these grades? Why? Because usually remember, if I am saying contracted pelvis, the mode of delivery is a C-section, no doubt. But if they specifically mention you, there is mild degree of contracted pelvis, you can try normal vaginal delivery. Okay, you can try. So, very important point. So, trial of labor can be done. Okay, trial of labor, which means normal vaginal delivery can be. You can have a trial with milder degree contracted pelvis, but in moderate or severe degree contracted pelvis, you have to always go with the C-section. Now, guys, please see in the next slide. Now let's see what exactly is a trial of labor. Guys, allowing labor in a female having milder degree contracted pelvis. What does I mean by milder degree contracted pelvis? That is in between 9 to 10 centimeters. Okay. So at the level of inlet. So at the level of inlet, if the obstetric conjugate is in between 9.5 to 10 centimeters, you can try normal vaginal delivery. If it fails, okay, you can go with the C-section. Okay, you can try milder degree contracted pelvis, a trial of labor. So, if it fails, you can do the C-section. But please concentrate, what are the contraindications for the trial of labor? You should never do trial of labor if there is moderate degree or severe degree contracted pelvis, or if she had any previous C-section. Definitely you are not going to do the normal vaginal delivery this time, right? So, previous C-section, no normal vaginal delivery. And if there is a malpresentation and milder degree contracted pelvis or severe degree contracted pelvis, doesn't matter. If there is malpresentation, you should never do trial of labor. And previously, okay, in the previous delivery, you have tried a trial of labor, but it is unsuccessful. Now, even this time, now she is having contracted pelvis, don't try trial of labor, okay? So, it's a contraindication. Now, if a female is suffering with a severe pregnancy-induced hypertension or diabetes or cardiac diseases, trial of labor is contraindicated, okay? So, these are some important points. Now, contracted pelvis, mode of delivery is C-section. But when trial of labor can be tried, if there is milder degree contracted pelvis at the level of inlet, then trial of labor can be done. If it goes wrong, you can do the C-section. Now, after this, let's talk about cephalopelvic disproportion. What exactly is cephalopelvic disproportion, sir? See, cephalus means baby's head. Pelvic means the pelvis of the mother. See, there is a disproportion between the head of the baby and pelvis. For example, in this particular pregnancy, the baby is having macrosomia. If the baby is having macrosomia, the baby will be having a bigger head, or the baby will be suffering with the hydrocephalus. The baby will be having a bigger head. So, having such a big head, baby cannot pass through the inlet. So cephalopelvic disproportion is there. The baby's head is bigger to the pelvis in this particular delivery. So important point is that cephalopelvic disproportion, is it a recurrent indication for C-section? Now remember, if there is cephalopelvic disproportion in this particular pregnancy, yes, you have to do the C-section for sure. But what about the next pregnancy? In next pregnancy also she have to go with the C-section? Not necessarily. See, what I am trying to put into your mind is, if there is cephalopelvic disproportion this time, next time cephalopelvic disproportion can be there, or next time there cannot be cephalopelvic disproportion. So it's not a recurrent indication for C-section, but having contracted pelvis is a recurrent indication for C-section. That's the one important point I want to put into your mind. Okay, see, either the fetus is too big or pelvis is small for this particular pregnancy. Okay, this pregnancy there is some abnormality. Now, if a female is having cephalopelvic disproportion in current pregnancy, it does not mean she will have cephalopelvic disproportion in the upcoming pregnancy also. So, it is not a recurrent indication for C-section. Now, what we can do here? See, best method to diagnose cephalopelvic disproportion is, yes, trial of labor. See, you can do the trial of labor. Now, whenever you are doing the trial of labor, for example, if there is cephalopelvic disproportion at the level of inlet or cavity at the outlet, now what you can do is you can go with the C-section. So, first you can do trial of labor, you can try. If it fails, go with the C-section. Okay. So, all important points regarding maternal pelvis I have covered. Okay. Hope the video is helpful. Thank you.